Let me first start by thanking the organizing committee for asking me to cover this topic, which is an important and controversial topic. We know the IVUS is useful for assessment for the diagnosis of coronary disease. Okay. Yeah, the IVUS is useful for the diagnosis by assessing the lesion and guiding the, also useful for the management of the patient by giving guidance for the intervention and optimization of the intervention. In the guidelines, it was given grade 2A for using IVUS for the assessment of severity of left main disease. We know there is using the angiogram alone is a poor tool for assessing the degree of stenosis. And this is, if you compare the angiogram by the functional of the lesion by using FFR, you see a lot of discrepancies. Those dots are all over. Also using the QCA, assessing the severity of left main, if we depend on the actual minimum luminal area, and there is a lot of discrepancy in QCA, so we cannot depend on just the angiogram. So the best way is to depend mainly on IVUS for assessing of the left main. And this was validated in a lot of studies, but I'll mention only this one study, the LITROS study that's from Spain, that depend on the minimal lumen area of 6 millimeter in the left main. And let's forget about the LAD and the circumflex. Depending on that, if you have a minimum lumen area of 6 square millimeter and you defer the lesion, you will get good survival. And survival probably better for the people, when you compare that with the people who have minimum luminal area less than 6 square millimeter and they get revascularized. Look at this Kaplan-Meier curve, but they are almost the same because the p-value is 0.3. However, if we have low minimal luminal area of less than 6 and you defer it, you'll get significant increase in MACE. Depending on whether you use FFR or IVUS, the results are the same for the long term for assessing the severity and the functional severity of the left main. However, in the consensus, which was published about 2 years ago in 2018, they really agreed on the minimum lumen area of 6 square millimeter. You can defer that and do no intervention, and the patient is safe. If the minimum lumen area is less than 4.5 square millimeter, this patient needs revascularization. And if we have that in the borderline between 4.5 and 6 square millimeter, we need further assessment by using functional status by adding FFR on top of the IVUS. And IVUS also is important in assessing the degree of the, not just the left main, in assessing the LAD and the ostium of the circumflex. The predictive value of angiogram alone by assessing the severity is very poor. The positive predictive value for the angiogram is only 41% for assessing severe ostial LAD, and also it's much poorer for the ostium of the circumflex. So we have to assess the ostium of the LAD and the circumflex using the IVUS. And just a practical point, if you do IVUS to assess the left main lesion, you have to put the catheter in the left main and do pullback, in the LAD and do pullback to the left main, and again switch to the circumflex and do pullback. You cannot assess the ostium of the circumflex by just doing the IVUS at the LAD and get an idea of the ostium of the circumflex when the catheter is only pointing toward the LAD. So other points of the IVUS and the benefit of the IVUS is assessing the angiographic artifact. This is the origin of the left main, which go upward and then make an angle. This is not a left main disease. This is just an artifact, and by doing IVUS, there were no disease in the left main, and we prevented the patient from having either unnecessary intervention or going for unnecessary bypass surgery. The most important part of the IVUS is assessing the lesion by getting an idea about the plaque, the volume of the plaque, and the morphology of the plaque, and the composition, whether there is calcium, is focal calcium, or round-shaped calcium, and this will give us the plan to prepare the lesion for further intervention. We know the left main, the previous two speakers covered those two major studies, the coaxial and the noble, and we're not going to go about the result of those studies, but we'll concentrate of using the imaging, how to improve our results. We have to optimize all the result of the left main PCI by everything, using the high team. They covered that, define the plaque modification technique, especially if there's calcified lesion, whether we need to prepare with a rotablator or orbital atherectomy, assess the best evidence support drug-eluting stent, appropriate stenting approach, whether to use one stent, two stent, and use the optimization by intravascular imaging. And later, after we finish the intervention, we have to optimize the medical therapy. So IVUS guidance can give us an idea whether we should use one stent or two stent, whether to do plaque preparation by assessing the calcification, and whether to do rotational atherectomy or other kind of atherectomy. Device sizing by assessing balloon dilation, and stent sizing, and doing the part, which is an important part for any bifurcation intervention. And optimizing the result by doing adequate, assessing the result of the intervention, and make sure that we have adequate stent expansion and full coverage of the lesion, so we won't have any geographic miss, and to get complete stent opposition, and make sure that there is no edge dissection, because edge dissection is a predisposing factor for stent failure, whether it's stent thrombosis or restenosis. Now, the preference of provisional stenting, and everybody knows about the result of ABC bifurcation or ABC main trial, which was presented at Euro PCR virtually about 4 months ago. But for the idea to proceed with provisional stenting when there is small circumflex and there is no ostial lesion in the circumflex, and the plaque burden is small in the circumflex. So whether it's Medina 100 or 110, and there is no significant disease in circumflex, whether plaque burden is less than 50, and the minimal lumen area for the ostium of the circumflex is above 3.5 square millimeter. We don't need to cover the other point. Now, if there is a need for two stents when we have no small circumflex, either dominant or codominant circumflex, and there is significant long lesion, more than 5 millimeter in the ostium of the circumflex, and there is complex lesion in the ostium, and narrow angle between the LAD and the circumflex, because the narrow angle predisposed for plaque shift and involvement of the ostium of the circumflex. That's give us better idea to proceed with two-stent approach. However, if we proceed with one stent approach and we get poor result after provisional stenting, that's mean residual stenosis more than 75%, reduced flow or dissection, or assessing the function of the circumflex by FFR, and when the FFR is less than 0.8 or the IFR less than 0.9. Now, using the IVUS is going to improve our outcome. Well, we have a lot of data now. Let's talk about the Korean experience. The Korean experience, just by using the IVUS and optimizing the result, we get a significant improvement in death and myocardial infarction, marginal or borderline improvement in TVR, On the long run, after 10 years, they got improvement in mortality. However, at the beginning, there were no improvement in the mortality. But you know, this is a different population in Southeast Asia, different body size and different lesion types. So if we go a little bit Western, this is the Spanish experience where they got case match of 500 case by using IVUS or not using IVUS. And with that, they got improvement in the total endpoint, whether cardiac death, MI, or target lesion revascularization, and significant reduction in the most important thing, that's stent thrombosis. So using IVUS is not going to improve just the outcome, but it's going to prevent the bad result. And they did subgroup analysis for the people who have just distal left main, or they did 2 stent intervention, and by using IVUS, they got significant improvement in this total MACE, whether it's cardiac death, MI, or target lesion revascularization. So using IVUS as predictor of outcome, whether it's death, MI, or target lesion revascularization, we know this is the most important thing. It decreased the incidence of the bad outcome by more than around 50%. It's 46%, because the hazard ratio is 0.54. So also, IVUS help us in making further decision. If we use IVUS, we'll get better sizing, and in most of the cases when we use IVUS, we decided to use better stent and decided to do more post-dilation. So IVUS gives the better idea for the assessment of the size of the stent and doing further intervention or further manipulation to improve the result. And this is the meta-analysis for all the study that used IVUS, and we got significant improvement that IVUS-guided PCI is much better compared to angiographic-guided PCI, and that's reflected on mortality and cardiac mortality. Now, if we go back to the Excel study, and the use of IVUS in the Excel. So they divided the result according to 4 quartiles, depending on the final minimum lumen area. And this is the highest final minimum area, that's more than 11 to 17.8 square millimeter. And with that, we got significant improvement in all this outcome, although the p-value is just at the borderline, but this is at 30 days. It's too early to assess the result. But look at 3 years. By getting the best result and more minimal lumen area, we got significant improvement in death, MI, stroke, and all death. All of that are significant, and the p-value is 0.01. So this is for the Excel. Again, for the Nobel, and everybody knows the result of the Nobel, but we'll discuss the sub-study of using the IVUS optimization on this. And they followed this patient, and let's review the 5-year MACE. There were no improvement in mortality. The p-value is 0.45. But if we get look at the target lesion revascularization, there is significant trend or a trend. Look at this improvement in target lesion vascularization if you use IVUS, 5.1 compared to 11.6, and the p-value is significant. Again, if we get better result by getting much larger minimum lumen area, the trend to improve mortality is much prominent. And look at our target lesion vascularization. 0 is 0 if you get the left main stem area or the minimum lumen area more than 13. So with that thing that using the IVUS is going to improve the outcome, but we need to put really a criteria to improve our result by putting a space or a map to which degree of ML we need to reach, and what kind of degree of edge dissection that we can accept. And with that, this is the optimal study is running now, and they are enrolling, depending now here on using a pre-specified IVUS endpoint. So we did review, this is the guideline, and this is the guideline for assessing the left main stenosis and assessing the guidance optimization for left main intervention. Now, if we use now the predefined optimization that we talked about compared to the IVUS, if we use predefined optimization, we'll get the best result. This is a small study from Spain, but we are waiting for the larger study from the optimal. And with that, they are looking for stent expansion. That means the maximum stent area is more than 90% of the main vessel area. So that's mean good expansion. It's beyond the topic of this lecture to explain all those things. So this is for the IVUS, and everybody talk about the OCT. The OCT, there are some data, but the data are new, and there is the data for the OCT in the left main is not standardized. So we are waiting for more data. However, there is this small study, the ROC2 study, and again, this is from Spain, that compared the OCT to the IVUS, and the results similar, but look at the difference compared to the angiogram. So we'll wait for the OCT, but however, the protocol for the OCT is that you do run before intervention, you do run after each step of intervention, after stenting, after optimization, after POT, and after post-dilation. Because it's simple catheter, it's not compared to the IVUS. And with that, we look for the MLD max. The MLD means assess the morphology of the plaque, the length of the plaques, and the diameter. That will give you the plan to which size to do pre-dilation and the stent. And the post-PCI OCT for the optimization, you look for the max. Max is medial dissection. That means the edge dissection, especially at the proximal part of the stent, the opposition of the stent, and the expansion of the stent. So now we talked about those two things, and everybody will say, well, I can do IVUS with my eye. I have an IVUS eye, and I can do everything without. And the reason behind this is one part of the doctors, and the other one who does left main intervention, he say, well, I always do IVUS for every kind of left main intervention. So let's see about the IVUS eyes. What's the reason for that? What's the supporting statement? Well, I learned from my experience. I always adhere to all the steps. I do POT, I do final kissing, and I do re-POT. And imaging is unnecessary cost and unnecessary time. And on top of that, my left main PCI outcome are good. So those are the points that the doctor who doesn't use IVUS for left main, they have. Now, those are the points. Now, can IVUS eye really happen? Let's look at the Excel. This is the study from the Excel done by David Kanzari, and that's comparing using one stent or two stent, and you see the difference in the outcome. By using two stent, we get increased incidence of death, stroke, MI, or ischemia-driven revascularization. Although IVUS was used in 75 of cases of the Excel study. So still with that, there is 30% event rate at 3 years. Is that acceptable if you do left main and you'll accept 30% outcome? Now everybody, well, this is because they use two stent and they use the T-tab, they do use the DK crush. But let's review the DK crush. If we compare the result. Now, for the Excel, we know all-cause death is higher in the XL, 11% compared to 6.7%.
Cognizant of time.
Sorry?
We're running a little bit late.
Yeah, I'm a little bit late, but you gave all the first two speakers more than 20 minutes, and we are covering, this is the most important part.
Okay.
But anyway, give me a couple of minutes, I'll be done. Okay. So the all-cause death is much higher in the XL, and the myocardial infarction much higher. The target lesion revascularization is much higher, and the definite stent thrombosis is much higher. So everybody would say, well, this is the answer. Let's go for DK crush. But in DK crush, the participating operator, they were requested to be doing more than 300 PCI a year and doing more than 20 left main PCI a year. So I don't think we have a similar kind of cardiologist here in UAE. I don't think so, but probably I'm wrong. So the pre-procedure IVUS was 28%, and the overall procedure IVUS is 40%. So with this, we have very good result, but with DK crush. But this is different operator, and remember again, it's different population. The people in South or in East Asia are totally different. They reported that the lesion length in the circumflex is so long, 15 millimeter, and we talk now here only the circumflex has focal lesion in the Western country and also in our population in the UAE. So that's totally different doctors and different patients, and we cannot depend on that. So let's go to the reality and review some of the data from the UK, since our chairman is from the UK and asking me to go faster. So this is the study from the UK, from the British Interventional Cardiac Society, and this is the registry, a big number, about 11,000 cases. And look at this. This is the people and their result. And they divided the cardiologists who did the intervention into 4 quartiles. And look at that. Most of the cardiologists in the UK, they have average of doing less than 5 intervention of left main a year. So very few, they are doing more than 20 intervention a year. So that means if we put that, only 11 UK operator could be used to enroll for the DK crush. So that's in the UK. I don't know how many of our cardiologists can. So the answer is not DK crush. And according with that, with this quartile, the people who have higher quartile, they are more experienced. They get significant reduction on all-cause death and revascularization and myocardial infarction. So being a high-volume operator may affect your result for the intervention and for the left main. And that's not reflected in this curve. Look at this in-hospital MACE, in-hospital mortality, 12 months mortality, and peri-procedure MI, in-hospital major bleeding, all reflected according to the volume. And this is also whether when you use IVUS, we'll get 30% reduction in mortality with left main imaging. So just using IVUS and affecting your decision by doing more intervention, more expansion, and more dilation may give you improvement in the mortality. And that's reflected also, although we got improvement by using IVUS, but also the best people who is doing more left main intervention and using IVUS got the best result. And that's with a nice editorial from Akiko Mahira, and hopefully she will be visiting UAE next month for the Gulf Interventional Society. She wrote a very nice editorial saying probably the best doctor knows how to use the IVUS best, and with that they got the better result. So intracoronary imaging usually associating with improvement in patient outcome, but not all left need images guided, but most of them can be optimized by using. So should all PCI operator undertake doing left main intervention? Should they use IVUS? So increased operator volume is an evidence base that it can enhance our patient outcome. So this is the conclusion. IVUS for left main is definitely helpful in assessing the left main lesion severity, evaluating the extension of the ostium of the LAD and the circumflex, characterize the left main plaque, plan PCI strategy, guide plaque preparation, and sizing the stent and doing path and optimize the PCI result. So IVUS guidance of left main provide prognostic benefit with respect to the use of angiographic alone, particularly in those with protocol predefined optimization. So get the advantage of IVUS when dealing for the